Your fingernails revealed a metabolic crisis I had no idea was occurring inside my body. When I finally understood what the horizontal ridges, the subtle discoloration, and the changes in nail texture were telling me, I discovered my fasting glucose had drifted to 118 milligrams per deciliter. My ferritin was critically low at 22 nanograms per milliliter, and my thyroid function was declining. All conditions that had been silently progressing for years without a single obvious symptom. I'm a professor of genetics at a major research institution, where I've spent over 2 decades studying metabolic regulation, cellular aging, and the molecular mechanisms that determine human health span. Today I'm sharing the exact diagnostic framework I now use to interpret nail pathology. 7 specific nail changes that serve as windows into cardiovascular disease, metabolic dysfunction, organ failure, and nutritional deficiencies that most physicians never discuss during routine examinations. The nail matrix is one of the most metabolically active tissues in the human body. It requires constant delivery of oxygen, amino acids, zinc, biotin, and iron to sustain keratinocyte proliferation. When systemic stress occurs, whether from acute illness, severe nutritional deficiency, or metabolic crisis, the matrix temporarily halts production. The result is a visible groove that travels outward as the nail grows. Here's the mechanism. During periods of severe physiological stress, your body activates what I call resource allocation triage. Blood flow and nutrient delivery are redirected away from non-essential tissues, including the nail matrix, toward vital organs. This process is mediated by sympathetic nervous system activation and cortisol-driven metabolic reprogramming. Research published in Clinical and Experimental Dermatology found that BEAU'S lines appear approximately 2 to 3 weeks after the causative event. And here's the remarkable part. Their position on the nail plate allows you to calculate when the stress occurred. Nails grow approximately 3 to 4 millimeters per month. If a BEAU'S line sits 6 millimeters from your cuticle, the metabolic insult occurred roughly 6 weeks ago. The most common causes include severe infection, like COVID-19 or pneumonia, high fever episodes exceeding 103 degrees Fahrenheit, chemotherapy or radiation treatment, uncontrolled diabetes with glycemic variability, severe zinc deficiency below 60 micrograms per deciliter, myocardial infarction or stroke, and major surgical procedures. When I noticed horizontal ridges appearing on multiple nails simultaneously, I immediately ordered comprehensive metabolic testing. My results revealed that a bout of viral illness 3 months prior had triggered significant zinc depletion. My serum zinc measured 58 micrograms per deciliter against an optimal range of 80 to 120. I implemented 30 milligrams of zinc picolinate daily with meals, increased my oyster consumption to twice weekly, and added 2 milligrams of copper to prevent zinc-induced copper depletion. Within 4 months, new nail growth emerged without ridging. Sign number 2, spoon-shaped nails, koilonesia. The second sign is koilonesia, which presents as nails that curve inward, creating a concave, spoon-like depression. If you placed a drop of water on the nail surface, it would pool in the center, rather than roll off. This deformity typically develops gradually and may affect multiple nails simultaneously. Spoon nails are the most reliable external indicator of iron deficiency anemia, a condition affecting over 2 billion people worldwide, according to the World Health Organization. Iron deficiency doesn't simply cause fatigue. It impairs oxygen delivery to every cell in your body, compromises mitochondrial electron transport chain function, and accelerates cellular aging through increased oxidative stress. Here's why this happens at the molecular level. Iron is essential for the structural integrity of the nail plate. The disulfide bonds between keratin proteins require adequate iron for proper cross-linking. When iron stores become depleted, keratin synthesis becomes disorganized, producing a nail plate that lacks the structural rigidity to maintain its normal convex curvature. More critically, Iron is the central atom in hemoglobin and myoglobin, the proteins responsible for oxygen transport. When ferritin drops below 30 nanograms per milliliter, oxygen delivery to peripheral tissues, including the nail matrix, becomes compromised. Research in the American Journal of Clinical Nutrition demonstrates that chorlonikia appears when ferritin levels fall below 20 nanograms per milliliter, often preceding anemia diagnosis by 12 to 18 months. Beyond iron, other causes include hypothyroidism, hemochromatosis, which is actually iron overload, Raynaud's phenomenon, systemic lupus erythematosus, and chronic exposure to petroleum-based solvents. My comprehensive iron panel revealed ferritin at 22 nanograms per milliliter, technically normal by conventional laboratory ranges, but far below the optimal 80 to 150 nanograms per milliliter I target for mitochondrial function. I implemented a multi-pronged approach. Grass-fed beef liver at 100 grams twice weekly, providing approximately 6 milligrams of heme iron per serving. Vitamin C at 500 milligrams with iron-rich meals to enhance absorption by 67%. Avoidance of calcium and coffee within 2 hours of iron consumption. And ferrous bisglycinate supplementation at 25 milligrams every other day. After 12 weeks, my ferritin rose to 89 nanograms per milliliter, and the concavity in my thumbnails began to normalize. Sign number 3, clubbing. The third sign is digital clubbing, characterized by enlargement of the fingertips, where the angle between the nail plate and the proximal nail fold, called the Lovibond angle, exceeds 180 degrees. The nail curves around the fingertip like a drumstick, and the nail bed becomes spongy when pressed. There's a simple test you can do right now called the Shamroth window test. Place the dorsal surfaces of 2 opposing fingers together, your 2 index fingers, for example. A diamond-shaped window should be visible at the nail bases where they meet. In clubbing, this window disappears. Clubbing is perhaps the most ominous nail sign because it indicates chronic hypoxia, insufficient oxygen reaching peripheral tissues. This hypoxia triggers a cascade of vascular remodeling mediated by hypoxia-inducible factor 1 alpha, platelet-derived growth factor, and vascular endothelial growth factor. The fingertips enlarge as new blood vessels proliferate in a futile attempt to increase oxygen delivery. The mechanism is fascinating and concerning. When arterial oxygen saturation remains chronically reduced, whether from pulmonary disease, cardiac dysfunction, or intrapulmonary shunting, megakaryocyte fragments that would normally be trapped in pulmonary capillaries bypass the lungs and reach the digital circulation. These fragments release growth factors directly into the fingertips, triggering connective tissue hyperplasia and vascular proliferation. Research published in Thorax found that clubbing precedes lung cancer diagnosis by an average of 9.4 months in 35% of cases. A landmark study in Chest demonstrated that clubbing appears in 35% of lung cancer cases, 40% of interstitial lung disease, 50% of bronchiectasis, 80% of cyanotic congenital heart disease, 20% of infective endocarditis, and 15 to 40% of inflammatory bowel disease. If you notice clubbing, this warrants immediate medical evaluation. Chest X-ray or CT scan, echocardiogram to evaluate cardiac function, pulmonary function testing including DLCO, arterial blood gas to assess oxygenation, and complete blood count to rule out polycythemia secondary to chronic hypoxia. I monitor the Lovibond angle of my nails quarterly. Any increase beyond 175 degrees prompts immediate investigation. Early detection of pulmonary or cardiac pathology can be life-saving. Sign number 4, half and half nails, Lindsay's nails. The fourth sign is Lindsay's nails, which present as a nail plate distinctly divided into 2 zones, a white or pale proximal half near the cuticle and a brown or reddish distal half near the fingertip. The demarcation between these zones is typically sharp and does not disappear with pressure. Half and half nails are a specific marker of chronic kidney disease, appearing in 20 to 40% of patients with end-stage renal disease, according to research in nephrology dialysis transplantation. However, and this is critical, they can appear when kidney function is only moderately impaired, with estimated glomerular filtration rate below 45 milliliters per minute. The pathophysiology involves multiple factors related to uremia. The proximal white zone results from chronic anemia due to reduced erythropoietin production and edema in the nail bed. The pale color reflects decreased vascularity and altered hemoglobin concentrations. The distal brown zone is caused by increased melanin deposition, secondary to elevated levels of melanocyte-stimulating hormone, which accumulates when kidney clearance fails. Additionally, urochrome pigments that cannot be renally excreted deposit in the nail plate. Research in the Journal of the American Society of Nephrology suggests that the brown distal band contains increased lipofuscin, a marker of oxidative damage, suggesting that the discoloration reflects systemic accumulation of advanced glycation end products and lipid peroxidation products. If you observe half-and-half nails, I recommend a comprehensive metabolic panel, including creatinine and BUN, cystatin C measurement, which is more accurate than creatinine, for early kidney dysfunction, urine albumin to creatinine ratio to assess proteinuria, and fasting glucose and HbA1c, since diabetes is the leading cause of kidney disease. Given that my father developed chronic kidney disease, I implement aggressive kidney protective strategies. Protein moderation at 1.0 to 1.2 grams per kilogram body weight, emphasizing plant proteins. Sodium restriction below 2,000 milligrams daily. Avoiding processed foods with added phosphate preservatives. Maintaining systolic blood pressure below 120 millimeters of mercury. Keeping HbA1c below 5.4%. And annual cystatin C measurement, because this biomarker detects kidney decline before creatinine rises. Sign number 5, Terry's nails. The fifth sign is Terry's nails, characterized by a nail plate that appears predominantly white or ground glass opaque, with a narrow band of normal pink color just 2 to 3 millimeters at the distal edge. The lunula, the white crescent at the nail base, may be indistinguishable from the surrounding whiteness. Terry's nails indicate hepatic dysfunction, specifically cirrhosis, in the majority of cases. Research published in The Lancet found that 82% of patients with cirrhosis displayed Terry's nails. However, they also appear in 50% of patients with congestive heart failure, 25% of patients with type 2 diabetes, and may appear in those over 80 without underlying pathology. The white appearance results from two concurrent processes. First, reduced vascularity. Hepatic dysfunction leads to decreased synthesis of vasodilatory substances, including nitric oxide precursors. And portal hypertension causes redistribution of blood flow away from peripheral vascular beds. Second, hypoalbuminemia. The liver produces albumin, the primary plasma protein responsible for maintaining oncotic pressure. When albumin synthesis fails, levels below 3.5 grams per deciliter, fluid shifts from the intravascular space into the interstitium, causing nail bed edema that obscures the normal pink color. Histological studies in the British Journal of Dermatology also demonstrate thickening of connective tissue in the nail bed of patients with Terry's nails. If you observe Terry's nails, particularly if you consume alcohol regularly or have risk factors for liver disease, I recommend a comprehensive liver panel, serum albumin and total protein, prothrombin time, and INR as a sensitive marker of synthetic liver function, hepatitis B and C serologies, and liver ultrasound with elastography. I maintain aggressive liver protective practices, complete alcohol elimination, since alcohol is hepatotoxic at any dose, choline intake at 550 milligrams daily through eggs and liver to prevent fatty liver, omega-3 fatty acids at 2 grams EPA and DHA daily to reduce hepatic inflammation, 3 to 4 cups of high chlorogenic acid coffee daily. Research in hepatology demonstrates a 44% reduction in liver disease with this intake. And silymarin supplementation at 200 milligrams twice daily for glutathione support. Sign number 6, pitting and crumbling nail psoriasis. The sixth sign is nail pitting, which presents as small punctate depressions scattered across the nail plate, like someone pressed the tip of a ballpoint pen into the nail surface repeatedly. When severe, the nail may become thickened, crumbly, and separate from the nail bed. The surface may develop horizontal ridging, yellow-brown discoloration called oil spots, and subungual hyperkeratosis. Nail psoriasis is not merely a cosmetic concern. Research in the Journal of the American Academy of Dermatology demonstrates that 80% of patients with psoriatic arthritis, a destructive inflammatory arthropathy, display nail involvement. Critically, nail changes precede joint symptoms by an average of 10 years in 15% of patients. Psoriasis is fundamentally a disease of immune dysregulation, characterized by Th17 lymphocyte overactivation and excessive production of interleukin-17 and interleukin-23. In the nail matrix, this inflammatory cascade accelerates keratinocyte proliferation and disrupts normal nail plate formation. The pits represent focal areas where parakeratotic cells, abnormally nucleated keratinocytes, were incorporated into the nail plate and subsequently shed, leaving punctate depressions. The oil spots result from accumulation of serum glycoprotein beneath the nail plate, where inflammation disrupts adhesion. Studies in arthritis research and therapy demonstrate that nail psoriasis serves as an enthesial disease marker. Inflammation at sites where tendons and ligaments attach to bone. The nail matrix is structurally connected to the distal interphalangeal joint via the extensor tendon enthesis, explaining why nail involvement predicts joint disease. Beyond the nails, psoriasis increases cardiovascular disease risk by 50%, independent of traditional risk factors. Research in JAMA Dermatology found that patients with severe psoriasis have a 3-year shorter life expectancy, 58% increased myocardial infarction risk, elevated inflammatory markers, and higher rates of metabolic syndrome. I implement comprehensive anti-inflammatory strategies. Elimination of seed oils, since linoleic acid converts to arachidonic acid, which is the substrate for inflammatory prostaglandins. Omega-3 optimization at 3 to 4 grams EPA and DHA daily, targeting an omega-6 to omega-3 ratio below 3 to 1. Vitamin D at 5,000 international units daily, targeting serum levels of 60 to 80 nanograms per milliliter, because vitamin D modulates Th17 activity. Quercetin at 500 milligrams twice daily to inhibit mast cell degranulation, and stress management, because chronic psychological stress elevates interleukin-17 production. Sign number 7, dark longitudinal streaks, melanonychia. The seventh and final sign is melanonychia, which presents as a brown or black band running lengthwise down the nail, from the cuticle to the free edge. The band may affect a single nail or multiple nails. While melanonychia is common and benign in individuals with darker skin tones, appearing in up to 77% of African Americans by age 70, it can also represent subungual melanoma, one of the most aggressive forms of skin cancer. Bob Marley's death from acral lentiginous melanoma, that began under his toenail, illustrates the lethal potential of this malignancy. Melanocytes reside in the nail matrix and produce melanin that becomes incorporated into the growing nail plate. Benign activation of these melanocytes, from trauma, pregnancy, medications, or ethnic variation, produces stable, uniform bands. Malignant transformation, however, produces characteristic features described by the ABCDEF rule. A is for age, peak incidence in the 5th through 7th decades, and ancestry, particularly African, Asian, or Native American heritage. B is for band characteristics, breadth greater than 3 millimeters, irregular borders, and variegated color ranging from brown to black. C is for change, rapid enlargement or evolution in morphology. D is for digit. The thumb, index finger, or great toe are most commonly affected. E is for extension. This is Hutchinson's sign, pigmentation extending onto the proximal or lateral nail fold. F is for family history of melanoma. Research in the Journal of the American Academy of Dermatology found that Hutchinson's sign, pigment extending beyond the nail onto surrounding skin, has a 77% positive predictive value for subungual melanoma. Any new or changing longitudinal pigmented band warrants dermatological evaluation. I recommend dermoscopy, serial photography to document changes over 3 to 6 months, nail matrix biopsy if concerning features are present, and full-body skin examination. I perform monthly nail inspections, documenting any pigmented bands with digital photography. I examine bandwidth in millimeters, color uniformity, border regularity, presence of nail fold pigmentation, and changes from prior photographs. Any band exceeding 3 millimeters, demonstrating color variation or showing nail fold extension, prompts immediate dermatology consultation. My complete diagnostic protocol, based on my research and clinical observations, I implement the following systematic nail assessment. For monthly self-examination, which takes about 5 minutes, I use a magnifying glass, pen light, ruler, and smartphone camera. I examine each fingernail and toenail in bright natural light, measure and document any pigmented bands, assess nail plate curvature, check for horizontal or vertical ridging, evaluate color, perform the Shamroth window test for clubbing, press on the nail bed to assess capillary refill, which should be under 2 seconds, and compare to photographs from the prior month. For annual laboratory assessment when any nail abnormality is detected, I recommend a comprehensive panel, including complete blood count, metabolic panel, iron studies with ferritin and TIBC and transferrin saturation, thyroid panel, including TSH and free T3 and free T4 and reverse T3, inflammatory markers, including CRP and homocysteine, vitamin levels, including B12 and folate and vitamin D, liver function tests, kidney function tests, including cystatin C, and metabolic function tests, including fasting glucose and fasting insulin and HbA1c. My measured results, since implementing systematic nail assessment and addressing the underlying conditions my nails revealed. Here are my results. For metabolic markers, fasting glucose improved from 118 to 88 milligrams per deciliter. Fasting insulin reduced from 12.4 to 4.2 microinternational units per milliliter. HOMA-IR decreased from 3.6 to 0.9, which is optimal. HbA1c dropped from 5.8% to 5.1%. For nutritional status, ferritin increased from 22 to 94 nanograms per milliliter. Zinc corrected from 58 to 102 micrograms per deciliter. Vitamin D optimized from 32 to 72 nanograms per milliliter. For inflammatory markers, high sensitivity CRP reduced from 2.8 to 0.4 milligrams per liter. Homocysteine decreased from 11.2 to 7.4 micromoles per liter. For nail appearance, BEAU'S lines resolved completely. Nail bed color returned to pink and uniform. Curvature normalized to convex architecture. Surface became smooth with no pitting. Questions I frequently encounter. How long does it take for nail changes to appear after disease onset? The nail matrix reflects systemic conditions, with a 2 to 3 week delay for acute insults producing BEAU'S lines, and 4 to 6 months for chronic conditions affecting overall nail architecture. Since fingernails take approximately 6 months to grow completely, and toenails 12 to 18 months, you're essentially viewing a 6 to 18-month health record in your nails. Are vertical ridges concerning? Vertical ridges, also called longitudinal ridging or onychorexis, typically reflect normal aging-related changes in nail matrix function. They become more pronounced after age 50 and do not indicate systemic disease in most cases. However, severe ridging with splitting may indicate nutrient deficiencies, particularly biotin, iron, or protein malnutrition. Can nail polish or artificial nails hide disease signs? Yes. Opaque nail polish prevents assessment of nail bed color, which is how you detect teres nails, half-and-half nails, and melanonychia. I recommend removing polish from at least one fingernail on each hand for periodic assessment. Artificial nails can cause mechanical trauma, producing BEAU'S lines and koilonychia that mimic disease. Do medications affect nail appearance? Multiple medications alter nail morphology. Chemotherapy causes BEAU'S lines. Retinoids produce nail fragility. Antimalarials can cause melanonychia. Certain antibiotics produce photoonycolysis. Always consider medication effects when evaluating nail changes. Should you see a dermatologist or your primary care physician for nail concerns? For nail changes suggesting systemic disease, clubbing, teres nails, half-and-half nails, koilonychia, start with your primary care physician who can order the appropriate systemic workup. For concerns about melanonychia, nail psoriasis, or other primary nail pathology, a dermatologist with experience in nail disorders is more appropriate. Closing thoughts. Your fingernails are communicating information about your cardiovascular, metabolic, hepatic, renal, and immunological health. Information that remains invisible to standard laboratory testing until disease has significantly progressed. The 7 nail signs I've outlined today: BEAU'S lines, koilonychia, clubbing, Lindsay's nails, teres nails, nail pitting, and melanonychia represent an early warning system that evolution provided, but modern medicine largely ignores. I discovered that my own nails were revealing iron deficiency, zinc depletion, and metabolic dysfunction years before these conditions would have produced obvious symptoms or abnormal laboratory values. By implementing the interventions I've described, targeted nutritional repletion, inflammatory modulation, and systematic monitoring, I've corrected these underlying processes and restored optimal nail morphology. I'm a professor of genetics studying cellular aging and metabolic regulation. The research I've shared today represents the intersection of clinical medicine, molecular biology, and practical health optimization. Your nails are telling you something. The question is whether you're listening. Examine your nails today. And if any of these 7 signs are present, pursue the appropriate investigation. Early detection of systemic disease can extend your life by decades.